infective endocarditis, there should be presence of organism in the blood, okay, which is known as bacteremia. My voice is clear? Is it clear?
Yes, ma'am.
Yes, ma'am.
Okay. Next is the cardiac defect. If there is any cardiac defect, then they are more they predisposed to the disease, okay, infective endocarditis. Especially if there is any cardiac defect, then patient will be having, they are more prone to have the subacute type of infective endocarditis. Suppose if there is valvular defect is there, congenital defect is there, or if the patient is having prosthetic valve, then they will be having the disease. And if there is any congenital defect, okay, from birth only, if it is there, then patient also can have the infective endocarditis. For example, if the patient is having bicuspid aortic valve, or if there is any mitral valve prolapse, then this disease will predispose to the endocarditis. Next, host factor is also very important. Like if the patient is having their immune system is suppressed due to some drugs, or due to some therapy, or due to some exposure to the drugs. So if immunosuppression is there, then they are more susceptible to have the disease. Next, if a patient is IV drug abuser, or if they are having some disease, okay, metabolic dysfunction like the diabetes, or the patient is alcoholic, or if there is any neutropenia or decrease in the level of the neutrophil count due to some other reason, so they will these conditions will predispose to the disease. Okay, so coming to the morphology, morphologically, the disease or the lesion which is there in case of the infective endocarditis, it is present in the heart valves. Okay, so those lesion, it is known as vegetation. Okay, so this vegetations, now depending upon which type of infective endocarditis it is, so it depends upon the size or the lesion, it depends upon the type. Okay, but in general, the vegetation, these are present in the mitral or aortic valve, or if the patient is IV drug abuser, that time the lesion or the vegetation, it is present in the tricuspid valve. And size of the lesion will vary from 0.5 to 2 centimeter. They are usually friable, so they can get dislodged. Now please mute your mic, all of you. Mute your mic, please. So the vegetation, it may be single or multiple, and it may involve one or more valves, and usually that vegetation consists of the organism. So there will be presence of fibrin, inflammatory cells. Along with that, there will be presence of the microbes. Okay, and those vegetations, when it is there, it will cause destruction of the valve. Okay, so destruction will be there, and those vegetations are usually friable, so they may get dislodged and go with the blood, reach the circulation, leading to embolism. So when you talk about the acute type of infective endocarditis, usually the vegetations are large, bulky, and measures around 1 to 2 centimeter. And when these large vegetations are there, it will lead to erosion and perforation of the leaflet. It may erode the underlying myocardium, and it will lead to abscess formation. Okay, abscess cavity will be there, and sometimes it will be present around the valve, so they may form the ring abscess. And when the vegetations are there, in case of the subacute type of infective endocarditis, the vegetations are smaller in size and they cause lesser erosion of the underlying valve. Now, another consequence or the important complication for the vegetation, or in case of the infective endocarditis, there is presence of the vegetation, and one of the important complication is the formation of the emboli. So they will cause embolization. So systemic emboli may form in different sites like the brain, kidney, or the spleen. So the embolus, once it reaches there, it will be lost in that area, okay, in these organs. So So since this embolus, they consist of the organism which is virulent, once it is there, it will cause abscess formation. Wherever it is lost in the distant organ, there it will cause the infarction. Along with that, there will be abscess formation, because that embolus, it consists of organism. So there will be septic infarct. So coming to the complications of the infective endocarditis. So it can be cardiac complication or embolism or renal. Okay. So when talking about the cardiac complication in case of the infective endocarditis, there will be abnormal functioning of the valve. So vegetation is there in case of the infective endocarditis. Vegetation is there in the valve. So it will lead to damage of the valve. There will be dysfunction of the valve. So that damage may lead to either the stenosis or regurgitation. And there will be abscess formation. So myocardial ring abscess will be there, and perforation of the aorta will be there. Okay, if the vegetation are there are present in the aorta, then there will be perforation of the aorta, or if it is present in the septum, there will be interventricular septal perforation, and may reach the pericardial layer, and that abscess will be there. Okay, if that vegetation will if it perforates and reach the pericardium, then that time it will lead to suppurative pericarditis, meaning there will be, because that vegetation will consist of the organism. Now that organism, once it reaches the pericardium, they will multiply and will lead to pus formation. Okay, and inflammation. So that is known as suppurative pericarditis. Okay, so that is another complication. Now next, the vegetation will lead to embolism. So if it is left-sided vegetation, the embolism may go it can reach various organs like the brain, heart itself, and spleen or the kidney. Okay, wherever it reaches, since it consists of the virulent organism, that organism will be lodged there in that distant organ and will multiply, leading to the abscess formation. Not only there is infarction, but there will be abscess formation. Okay, if it is the brain, so there will be cerebral infarct or there will be abscess. If it is heart, there will be myocardial infarction. If the embolism is there in the spleen, there will be abscess formation in the spleen along with the infarction. If it is involving the kidney, then there will be abscess formation in the kidney. Now, if the vegetation is there in the right side of the heart, then the embolism will go to the lung. Okay, from the right side of the heart, from the right ventricle, through the pulmonary vessel, it will reach the lung. So in the lung, it may lead to infarction, then abscess formation, then pneumonia. Okay, so large part of the lung will be involved, so consolidation will be there, so leading to pneumonia. Next is the kidney. In the kidney also, depending upon the severity, it may have glomerulonephritis. Okay, inflammation of the glomeruli may occur, and there may be infarction because of the embolism, and there may be abscess formation in the kidney, or in advanced cases, if it is not treated, it may lead to renal failure. So what range of involvement is there? There may be glomerulonephritis, or there may be infarction, or there may be abscess formation, or there may be renal failure. So complications, there are three types. Cardiac complication can be there, involvement of the heart in the heart itself. There may be abnormal functioning of the valve can be there, or maybe abscess formation, or maybe perforation of the aorta or the septum, or there may be pericarditis. And another complication may be there because of the embolism, and another complication is there in the kidney. Renal complication will be present. Now coming to the clinical feature, once the patient is having infective endocarditis, there is inflammation, there is vegetation, lesion is there, and it is containing the virulent organism. Okay, so infective endocarditis means there is vegetation, there is inflammation, and the heart is involved. So since because of the infection, clinically patient will present with the fever. Systemic presentation will be there with the presence of fever, and there will be weight loss. Okay, and there may be anemia. Next, because of the involvement of the heart, and since the lesion is there, visitations are there in the heart valves, so patient will present with the murmur. Okay, because of the lesion and also because of the complications associated with the visitation, so there will be features which are presenting as the heart lesions. They clinically they will present with the murmur, or in advanced cases they will be left ventricular failure. Next, clinical features will depend upon the embolism. Next, complication. Okay, since the patient is having visitation, they will be they are more prone to have embolism, and that embolism may affect various organs. So clinically, depending upon the involvement of the organ and depending upon the severity, and depending upon the complications, the clinical features will be there. Okay, for example, if the patient is having brain infarction or abscess in the brain, so not only the general feature will be there, but general systemic feature like the fever and weight loss will be there, but there will be presence of the neurological symptoms, signs and symptoms. Okay, like paralysis or paraplegia, or the weakness of the limbs, or okay, so all those features will be there. Or there may be stupor, there may be coma. So depending upon the severity, all these features will be present. Or if there is involvement of the kidney, renal infarction, then again all the renal features will be there. There will be high serum creatinine level, and urine output may be reduced. Okay, so along with the cardiac problem and the systemic problem, if other problems are there, so you have to think about the embolism. Okay, you have to think that other organs are also involved. So other clinical features are there depending upon the involvement of the organ. For example, if the eye is involved, okay, so there can be retinal hemorrhage in the eye. Suppose there may be a small embolism maybe there in the vessel of the eye, and there can be hemorrhage also can be there. Clinically they will present as the rod spot. When you go to the when you investigate those patients, and when you do the fundoscopy, that time there will be you'll see that some spots will be there, and those are due to the presence of the hemorrhage, retinal hemorrhage, which is known as Rod's spot. Okay, so this is the fundoscopic image, which you see directly visualize the retinal layer with the help of the fundoscopy. So fundoscope, so you can see these are the vessels, this is the hemorrhagic area. Okay, next is the splinter hemorrhage. When you see the patient with the infective endocarditis, you can see that this is the splinter hemorrhage in the toenails or the fingernails. You can see like this linear dark area, which are due to the hemorrhage. Okay, and next is the Osler's node. So in the patient, in this patient, there may be painful infarct in the pulp or of the fingers or the toes. You can see here this redness, a nodular lesion is there, and these are all due to the infarction. Okay, so maybe because of the smaller vessels, they are embolized. Okay, and because of the blockage of the vessel, this tissue is undergoing infarction. There is a painful lesion is there. Okay, there's pain and little raised area, which is known as Osler's node. And a patient may present with the painful macules or patches like this. Redness is there, which may be present in the palmar or plantar area, which is known as Janeway lesion. Okay, so these are all signs which you see when you examine this kind of patient, or the patient having infective endocarditis. Now diagnosis is there with the clinical history and the clinical findings. You have to confirm the case of infective endocarditis. So for the confirmation, first you can see whether the organism is there in the blood or not. Okay, so with the clinical history and the physical examination, and also you have to do the blood culture to rule out the organism in the blood. So you have to see the organism in the blood, you have to do the blood culture. Okay, and you can take the samples, that is the blood can be taken at different times. So we talked about the visitations. In case of the infective endocarditis, there were two types of visitation. Okay, so last time previously we talked about the visitation in case of the rheumatic heart disease also. Yes or no? Do you remember?
Ma'am.
In rheumatic fever also there was presence of lesion, okay, in the valve, and that was also known as vegetation, isn't it? So vegetations, it can be present in the rheumatic fever also and infective endocarditis also. Okay, not only that, it can be present in other conditions also. For example, if the patient is having endocarditis where the organism is not involved, okay, which is known as NBTE or non-bacterial thrombotic endocarditis. Okay, remember, in case of the infective endocarditis, vegetation is there and those vegetations are containing the organism. Okay, whereas in the case of the NBTE, vegetations are there, but you don't find any organism. Okay, so those vegetations are usually sterile, meaning they are not containing any vegetation. So that is non-bacterial thrombotic endocarditis. Usually these vegetations are small, up to 1 to 5 millimeter, and they are usually sterile, meaning there is no organism, and fibrin and platelet thrombi will be there. Okay, so these vegetations are formed due to the presence of the fibrin and the platelet thrombi, and these are present along the line of the closure. When you talk about the valves, these vegetations are present along the line of the closure, and most commonly these are present in the mitral valve. Okay, but this vegetation, just like the vegetation present in the infective endocarditis, may also embolize, but they are sterile. Okay, so usually this kind of vegetations are present when the patient is having any malignancy or sepsis or other illness. Okay, so this kind of vegetation, it is also known as merentic endocarditis. Okay, so when you talk about the non-bacterial thrombotic endocarditis, there will be presence of vegetations, and these are present along the line of the closure. Mainly can be present in any valves, but mainly present in the mitral valve, and they are sterile, meaning there is no presence of any bacteria. They are formed because of the thrombi, which are formed due to the fibrin and the platelet. And here, if it is associated with the malignancy, sepsis, and other illness, usually they are associated with these conditions, and that time it is known as merentic endocarditis. Now, next is the vegetation, which is seen in the autoimmune conditions like the SLE, systemic lupus erythematosus. Okay, so that time it is known as Lehmann-Sachs endocarditis. Mostly it involves the mitral and tricuspid valve, and here the vegetations are small and they are present in both the sides of the calves. Okay, so one of the important feature in Lehmann-Sachs endocarditis is that the vegetations are sterile, meaning there is no organism. They are small and they are present in on both the sides of the cusps. So you can see this picture. These are the vegetations which are seen in case of the rheumatic heart disease. Okay. So rheumatic heart disease, vegetations will be present in the heart valves. You can see these are smaller in size. And the vegetation in case of the infective endocarditis are also present in the heart valves, but the vegetations, these are larger in size, like this lesion, and they will contain the organism. Next is the non-thrombotic bacterial, non-bacterial thrombotic endocarditis, where the vegetations are there, but they are smaller in size and they don't contain any organism. Next is the vegetation which is present in case of the autoimmune condition like the SLE, which is known as Lehmann-Sachs endocarditis, where the vegetations are sterile vegetations, are smaller in size and are present in both the cusp. Okay, like this side, and on both the side it is present. Understood, everyone? Any questions? Is it clear? How many of you understood? Raise your hand. Okay, out of 87, only 66 have understood. Others are absent, roaming around or sleeping. Okay. Okay, fine. So today, so that finishes your infective endocarditis. Okay. Now, coming to the today's topic. Actually, last time we could not finish, so that was about the last time's class. So today's class actually is about the myocardium. Okay. So all of you know the cardiac muscle, cardiac in the heart. There are three layers. Outer is the pericardium. Okay. And the middle is the myocardium, which consists of cardiac muscles, and the inner is the endocardium. Okay, endocardium is there, myocardium is there, or pericardium is there, also known as epicardium. Okay, in the visceral pericardium. So today we'll be talking about this part, this middle part, that is the myocardium. So involvement of the pathology involving the myocardium. Okay, that is non-ischemic myocardial diseases. Okay, so previously we talked about the ischemic heart disease, and ischemic heart disease basically it was involving the myocardium, isn't it? So today we'll be talking about the myocardial disease, but there is no ischemia. So there are two non-ischemic myocardial diseases: myocarditis and cardiomyopathy. So basically, myocarditis is the inflammatory process, primary inflammatory process of the myocardium. If you remember, in case of the ischemic heart disease also, we discussed about the myocarditis, meaning there was inflammation. Okay, but to call it as myocarditis, there has to be inflammation without any ischemic changes. Okay, for the myocarditis proper, it is actually defined as the primary inflammatory process which is involving the myocardium without any ischemic changes. So causes, they are divided into two categories: infectious and non-infectious. Basically infectious means like the other systems. Infectious, it involves the inflammation of the cardiac muscles by infection with the virus or chlamydia, rickettsia or bacteria. Okay, so infectious, some causative agent is there which is leading to inflammation of the myocardium. So various viruses will lead to inflammation of the myocardium, but most commonly it can be due to the infection with the Coxsackie virus A and B, which is most important, followed by the ecovirus or the HIV. Other infectious causative agents are there, like the chlamydia, psittaci, which is psittaci, leading to psittacosis, rickettsia, typhi, in case of typhus fever, and other bacteria are there which is leading to, or in this condition, patients are more prone to have myocarditis. Okay, like the Corynebacterium, diphtheria, in case of diphtheria, or if the patient is having Lyme disease caused by the Borrelia. In those patients, they are more prone to have myocarditis. Okay, so these are the infectious agent. And not only that, even the fungal infection, patient can have myocarditis, especially if the patient is having candidiasis, or any protozoal infection also patient can have the myocarditis. If the patient is infected with trypanosoma, in case of leading to Chagas disease. So if the patient is having Chagas disease, that time also they are more prone to have myocarditis, or the myocardium is involved. Next, toxoplasmosis caused by the Toxoplasma protozoa. That time also patient can have myocarditis. Sometimes the helminthic infestations also will lead to myocarditis, like the trichinosis, okay, caused by the trichinella. So that time also patient can have myocarditis. So these are the infectious conditions. So infectious means not only bacteria, it includes the virus, chlamydia, rickettsia, fungi, protozoa, helminths. So all these things, most importantly the mentioned, will lead to myocarditis. Not only that, myocarditis can occur in case of non-infectious conditions also. If the patient is having some for example, autoimmune condition, or if there is any drug hypersensitivity reactions, or if there is any giant cell myocarditis, that time patient may develop myocarditis. So coming to the morphology, if when the patient is having myocarditis, how the myocardium will look like grossly, how it will be, and histologically how it will be. Okay, so that includes the morphology. So with the naked eye, how the heart will be when the myocardium is involved, when the patient is having myocarditis. So grossly the ventricles are flabby, and there may be hemorrhagic mottling in the ventricular wall, and the disease may be patchy, maybe because there may be multiple focal involvement of the myocardium, and in this case the patient is having myocarditis, inflammation of the myocardium is there, so that time the endocardium is not involved. Okay, so the endocardium and the heart valves are not involved, they are not affected, but the wall is affected here. So hemorrhagic mottling can be there, and the ventricles are usually flabby. Histologically, if you see the myocardium, there will be inflammatory cell infiltrate. Okay, basically there will be presence of lymphocytes, and they can be depending upon the condition. If the patient is having some drug hypersensitivity reactions, or if the patient is having some Chagas disease, okay, so that time you can see eosinophils. Okay, so if you see any eosinophil in the myocardium, eosinophilic infiltration, that time you have to think about the parasitic infestations, or some drug hypersensitivity reactions, or the Chagas disease. There can be features of degeneration, or there can be features of necrosis in the myocytes. And if this is a case of the giant cell myocarditis, you can see multinucleated giant cells. Okay, and histologically also you can see that there are focal involvement or patchy involvement in the myocardium. Okay, so the patient is having myocarditis. Grossly, the heart ventricular wall are flabby, and there may be mottling because of the hemorrhage. There may be patchy discoloration. Okay, so that is known as mottling. And you can see there are the disease is patchy. And another important thing is that the patient is having myocarditis, so heart valves are generally not involved. Okay. Next thing is that histologically, patient is having myocarditis. In the myocardium, you can see various inflammatory cells, mainly the lymphocytes. But if there is any drug hypersensitivity reaction or parasitic infestation, that time you can see eosinophilic infiltration. And you can also see the features of degeneration or the features of necrosis in the myocytes. And if that is the case of giant cell myocarditis, there will be presence of multinucleated giant cells. Now, clinically, how they present. Now, the patient is having myocarditis. That patient is not having any ischemic heart disease, but inflammation of the myocardium is there. Okay, and there is no valve involvement. But how the patient will present? Okay, so that you have to think. So clinically, there is a wide variation in the clinical signs and symptoms. So the patient may be asymptomatic, or suddenly there may be death of the patient. Okay, sudden death can be there. Usually these are present with the dyspnea. Usually the patient will present with the dyspnea, that and there may be fever, there may be palpitation, and there may be murmur in the heart. Okay, and it may develop later on after 10 to 20 years after having the myocarditis. Patient may develop dilated cardiomyopathy. Okay, we'll be talking about this topic in the next slide, in the coming slide. And so that is one of the complications for the myocarditis. So after 10 to 12, 20 years, patient can have dilated cardiomyopathy. And death of the patient can be there suddenly due to the heart failure or due to the arrhythmia. Okay, but in general, they may be having dyspnea, they may be having, like shortness of breath can be there, they may be having fever, they may be palpitations, okay, and may present with murmur at times. And but usually patient may develop cardiac features later on after 10 to 20 years later. They may have dilated cardiomyopathy. And usually the diagnosis, confirmatory diagnosis, it is by the endomyocardial biopsy. Only after the biopsy, you can confirm that patient is having myocarditis. Okay, so that is all about the myocarditis. Now coming to the cardiomyopathy. Okay, so what do you mean by cardiomyopathy? This is another term. This is a broad term actually. Okay, cardiomyopathy is a broad term which under which involves various cardiac problems. Okay, so it is a heart disease resulting from a primary abnormality in the myocardium. So generally, cardiomyopathy means it is a broad term which denotes the disease mainly involving the myocardium. Okay, the cardiac muscles. Okay, so this cardiomyopathy may generally there are of three types. Dilated cardiomyopathy, which is in short we call it as DCM, dilated cardiomyopathy. Next is the hypertrophic cardiomyopathy. Next is the restricted cardiomyopathy, least common. And among these three cardiomyopathies, the dilated cardiomyopathy is most common one. Are you getting me, all of you? My voice is audible? Is it clear?
Yes.
Yes, ma'am.
Okay. Okay. So we'll be talking about this topics one by one. Actually, I'm having throat pain. Throat pain is there, whether it is, I don't know, is it just a viral, normal viral infection of corona? I don't know. Uh, okay, talking about the dilated cardiomyopathy. It is also denoted as DCM. Okay, so dilated cardiomyopathy, another, it is also known as congestive cardiomyopathy. And when do you call as dilated cardiomyopathy? So this DCM, it is characterized by progressive hypertrophy and dilation of all the four chambers. Okay, patient is having the progressive hypertrophy and later on dilation of all the four chambers. You know, there is a right and left atria and then right and left ventricles. So in case of the dilated cardiomyopathy, all the four chambers are dilated. Okay, so progressive dilation of the four chambers are there, and because of that, the uh, heart, which is already dilated, it cannot contract properly. Okay, so usually they will be having systolic dysfunction. So they are known as congestive cardiomyopathy. Okay, understood, everyone? Are you understanding the term? All of you, please remember, rather than just mugging off, you have to understand the term. Okay, so if you understand each and every term, then it will be easier for you to understand the whole chapter. Okay, so dilated cardiomyopathy, in this case, just remember dilated word is there. So cardiomyopathy word is there, means it denotes the heart, and dilated word is there. Just remember, all the heart chambers are dilated here. Okay, there's dilation of all the four chambers of the heart. Atrium is dilated, ventricles are dilated. Both the atrium, both the ventricles are dilated. And always remember, it is a progressive condition. Dilatation, it doesn't occur suddenly. Okay, it happens slowly. Over the span of years, the ventricles are dilated. Initially, maybe it is hypertrophied, but later on, they will be dilated with the time. So always remember, dilated means all the chambers are dilated, and this dilated chambers, the heart wall, it cannot contract. Okay, so cannot contract means there is systolic dysfunction. Okay, systolic means contraction. So since it cannot contract, there is systolic dysfunction. So when there is systolic dysfunction, there is congestion. Okay, so that's why it is also known as congestive cardiomyopathy. So what are the causes of the dilated cardiomyopathy? There are various causes. It may be due to toxins. Toxins can be due to the alcohol, or maybe due to the nutritional deficiency, which is known as beriberi, and it may be due to the viral myocarditis. Okay, especially when it is caused by the Coxsackie virus, as we discussed in just the previous slide. If the patient is having myocarditis after, especially if the patient is having viral myocarditis after 10 to 20 years, they are more likely to develop the dilated cardiomyopathy. Okay, which is one of the cause of death. Okay, sudden death of that patient having myocarditis. Mainly the viral myocarditis infected with the this Coxsackie virus. That time patient will develop cardiomyopathy, this dilated cardiomyopathy. Next, the drugs like adriamycin or doxorubicin also will lead to dilated cardiomyopathy and may be related to the pregnancy. Okay, so that time also the patient may develop cardiomyopathy. Next is the morphology. Now, remember in the DCM, dilated cardiomyopathy, whole the chambers are dilated. So grossly, obviously, the heart is enlarged. Okay, heart is large and flavy because all the walls are dilated and thinned out. And because of that, there is stasis of the blood. The blood in the heart, it is stasis, very slow flow will be there. So that will predispose to the thrombi formation. Okay, in the heart, there will be thrombi formation. And histologically, there will be hypertrophy of the heart will be there, and there will be fibrosis of variable degree. Since the disease is gradually forming, you can also see that the heart muscles have been hypertrophied, though it is dilated. Okay, and with time it has occurred. So fibrosis of variable degree is there depending upon the severity. You can see here, this is the normal heart with the arterial chambers and the ventricular chambers. These are all the wall of the heart. And you can see this is dilated cardiomyopathy, DCM. Initially, to have DCM, the heart muscles are hypertrophied. Later on, they are dilated. So these chambers, you can see the chambers are all dilated, and the heart is the hypertrophy of the heart muscles are there. Okay, so this is the the surface area is increased, so there is congestion. Okay, so that's why one of the complication is the thrombi formation, because the stasis of the blood is there in this uh, dilated chambers, because there's systolic dysfunction. It cannot contract properly. Okay, fully it cannot contract. If there's a contraction, then only it is pushing the blood. There's flow of the blood is there, because it is pushing the blood to the pulmonary vessels or the systemic circulation. But there is no there's systolic dysfunction, so they are all the time, so they will predispose to the thrombi. You can see here there are this picture, gross picture is showing the enlarged heart where there is flabby heart wall, and there is the ventricles are dilated. Okay, dilation of all the chambers. And you can see histologically there is fibrosis. This is actually the special stain. It is not HN stain section. This is special stain, that is the Mechen's trichrome. So there is fibrosis, and there the cardiac muscles are hypertrophied. Okay, you can see the hypertrophy of the cardiac muscles, and there is variable degree of the fibrosis, which is demonstrated by the special stain, which is blue in color. Fibrosis, collagen fibers are blue in color. Okay, these are all collagen fibers. Clinically, if the patient is having DCM, how they present? Okay, what is the age group? So most of the time, the DCM, depending upon the condition or depending upon the etiological factors, it varies widely. Okay, the patient having DCM, it varies widely. For example, if the patient is having myocarditis due to some infectious agent, they may develop DCM in early age also. Okay, in the middle age also, the DCM may develop later age also. So it varies depending upon the etiological factors. So since the chambers are dilated and congestion is there, so cardiac output is decreased because of the systolic dysfunction. The heart cannot pump the blood. There is no contraction. Okay, so because of that, there is a decrease in the cardiac output. Later on, it may lead to cardiac failure. Prognosis, it depends. It is not good. Usually, most of the time, 25% of the cases, they may survive up to 5 years. Okay, usually the prognosis is not good. Only 25% they will survive up to 5 years. Now coming to the hypertrophic cardiomyopathy. So that finishes the dilated cardiomyopathy. Have you understood, all of you? Any questions? Are you there?
Yes, ma'am.
Okay.
Yes, ma'am.
Okay, fine. So that was a dilated cardiomyopathy, that is at DCM. Okay. Now coming to the hypertrophic cardiomyopathy. From the term itself, from the name itself, you have to know the disease part. Okay. Here it is hypertrophic cardiomyopathy. It is also known as the synonyms are idiopathic hypertrophic subaortic stenosis, also known as hypertrophic obstructive cardiomyopathy, or also known as asymmetric septal hypertrophy. Okay, so hypertrophic cardiomyopathy denotes, or it is also termed as idiopathic hypertrophic subaortic stenosis. So these are all depending upon the etiological factor. What the etiology which is leading to hypertrophic cardiomyopathy. So accordingly, the name has been given. Okay, here the first one is the idiopathic hypertrophic subaortic stenosis, meaning the patient may be having aortic stenosis. So because of that, there is hypertrophy. Okay, hypertrophy of the ventricular muscles, and the cause for the stenosis may not be known. So it is idiopathic. Okay, so the term has been given as idiopathic hypertrophic subaortic stenosis. Or another may be hypertrophic obstructive cardiomyopathy. Due to some obstruction, there is hypertrophy of the cardiac muscle. Or next, there may be hypertrophy of the septum, of the ventricles or the aorta. So asymmetric septal hypertrophy. Wall may not be involved, but still there is hypertrophy of the heart muscles, mainly involving the septum. Okay, septum means it is a wall which is between the two ventricles and which is between the two artery. So it is termed as asymmetric septal hypertrophy. Now, talking about the hypertrophic cardiomyopathy, when do you call it hypertrophic cardiomyopathy? So it is characterized by heavy muscular hypercontracting heart, okay, opposite to the DCM. In the DCM, there is dilation of the chambers, okay, but here in case of the hypertrophic cardiomyopathy, there is heavy muscular hypercontracting heart. Okay, in the DCM, there is systolic dysfunction, meaning heart was not able to contract. But in case of the hypertrophic cardiomyopathy, heart is contracting more. Okay, it is hypercontracting. So heavy muscular hypercontracting heart is present. Next, but in this case, there is poor diastolic relaxation, meaning there is diastolic dysfunction. Hypertrophy of the heart is there, it is contracting very much, but it cannot relax. So relaxation is denoted by the diastolic, by the word diastolic. So there is poor diastolic function or diastolic dysfunction is present. Again, it is opposite to the DCM. In the DCM, diastole can be there, but systolic dysfunction is there. In the hypertrophic cardiomyopathy, there is diastolic dysfunction. Next is the massive myocardial hypertrophy without ventricular dilation. There's massive myocardial hypertrophy. You know the word hypertrophy, isn't it? Yes or no? Yes or no?
Yes, ma'am.
What do you mean by hypertrophy?
Yes, ma'am.
Okay, what do you mean by hypertrophy?
Increase in
How
cell
did you?
size.
Okay, yeah, there is cell size. Okay, it is not cell number, but increase in the cell size. The cardiac muscles size are increased, so there is massive enlargement of the myocardial cell, and there so cells are increased. So hypertrophy is there in general, but there is no ventricular dilation. Okay, again, this is always remember in the DCM there is a dilation is there, few hypertrophy can be there, but usually ventricular dilation is there. But here there is massive hypertrophy, and because of that there is more contraction, but there is less relaxation. Okay, so diastolic dysfunction. So outflow from the left ventricle may be reduced. Contraction is there, but there is no relaxation. There is no relaxation means there is no diastolic feeling. Okay, unless there is diastolic relaxation, there's feeling of the heart chambers, ventricular chambers, isn't it? But since there is no relaxation of the heart muscles, the space is very less. So feeling defect is there. There's no feeling. So that's why outflow from the left ventricle is reduced. Okay, outflow is reduced. You can see this picture, then only you will understand. So this, you can see these are the chambers, left atrium, this left ventricle. This is the size of the chamber. In case of the hypertrophic cardiomyopathy, there is massive hypertrophic cardiomyopathy, meaning the heart cardiac muscles are hypertrophied, okay, massively. And so there's a diastolic dysfunction. It cannot relax. Okay, only contraction is there, but cannot relax. Since it cannot relax, there's diastolic dysfunction. The feeling is not there. The amount of the blood which is coming from the left atrium to the left ventricle is reduced. Okay, it cannot accommodate more amount of the blood. So because of that, the ventricle, though it is contracting, it cannot it doesn't have a more amount of the blood to push, okay, to push into the aortic uh, in the aorta. Okay, so that's why the cardiac output is reduced. Though the blood is there, adequate blood is there in the left atrium, the ventricle doesn't have the capacity to accommodate that blood, which is pumped by the left atrium. Okay, why? Because of the hypertrophy of the muscle. The space, it is all occupied by the hypertrophied cardiac muscle. Okay, so that's why though the contraction is there, the sufficient amount of the blood is not present. Okay, that's why there is decrease in the cardiac output. Understood, everyone? Understood?
Yes, ma'am.
Okay, that's why the outflow from the left ventricle may be reduced. Okay, so talking about the morphology, there is marked hypertrophy. Grossly also you can see the heart wall, the ventricular wall, they are hypertrophied. Okay, and there is no dilation, and it affects mainly the left ventricle more than the right ventricle. Okay, so left ventricular wall muscles are hypertrophied. There's marked hypertrophy of the left ventricular wall than the right ventricular wall, though in the right ventricle also the hypertrophy is present. And also there is increase in thickening of the interventricular septum. Okay, there is increase in the thickness of the interventricular septum. The left cavity is compressed, which looks like banana. You can see this is the cavity in this picture. This is a gross picture, cut section. Okay, you can see the hypertrophic muscle is there. Cardiac muscles are enlarged, thickened, and which is known as hypertrophy. And you can see this is the ventricular chamber, which is compressed. Okay, because of the hypertrophied wall. So it looks like banana shape, which is very characteristic, peculiar. And outflow from the left ventricle also is compressed. Okay, so histologically, obviously the cardiac muscles are hypertrophied, and there is a disarray of those myocytes, meaning they are arranged haphazardly. Okay, so histological also you can make out the size of the cardiac muscles are enlarged. Okay, I don't have picture here. Size of the cardiac muscles are enlarged and they are present haphazardly. And grossly, the ventricles are affected, mainly the left ventricle is affected, and the wall is thickened, even the septum is thickened, and the wall, the chamber is compressed, and it looks like the banana. Okay, and outflow from the left ventricle may be compressed. So this is all about the hypertrophic cardiac muscle. We'll finish up to this. We'll do up to this much. Okay, we'll continue in the next class. Okay, all of you. Today I'll be uploading only the previous class. Okay, not the today's one. Oh, now it is 91 at the end of the class. It was only 88. Anyway, your entering time and the exiting time, leaving and joining, it will be all recorded accordingly in your that attendance. It will be noted. Okay, so that is all about today's class. We'll be continuing in the next class. Still few are there. Okay, so I'll download your attendance first of all. Like the screen is visible.